Good morning, Professor Ho. Can you hear me? Can you hear me, Professor Ho?
Hi.
Hi. I'm wondering, like, what's happening?
I had a bit of anxiety just now because I couldn't get back to the, sorry, I'll just stop the other screen. Apologies. Yes, so I better try sharing the other screen.
Yes, you are able to share before. I could see your screen, so we should be fine. We should be fine. But anyway, you're trying to be just on time. Officially, I want to welcome Professor Joy Ho AM joining us for another very important session for our conference today. Thank you so much for joining. You've been a very good supporter for our events and information, education over the years. And so it just felt right that you are part of this important event for us, the inaugural Sickle Cell Conference for Australian Sickle Cell Advocacy. I welcome you and we thank you so much for joining you. We'll ask questions at the end. So you can go ahead, Professor Ho. Thank you.
Thank you very much, Agnes. I first basically want to thank Agnes for all her important work in advocacy and for the Australian Sickle Cell Advocacy for inviting me to speak. Agnes asked me to talk about gene therapy, and I must start off by saying that the experience of myself and my unit is in gene therapy and thalassemia. However, the same gene therapy that we used is also applied in trials in sickle cell disease. So as she told me that there would be interest in the clinical information, and as this is a sickle cell disease meeting, I will use our experience in thalassemia as a basis to report to you some of the important information and literature that have been presented and published in sickle cell disease. So in talking about gene therapy in the haemoglobinopathies, it's important to realize that the current successes have occurred within the context of a long history of difficulties. As many of you will know, in the mid-1990s, the concerns of gene therapy-associated malignancies led to a significant pause in the field. And in a very simplistic way, myself speaking as a physician rather than a scientist, some of the major problems could be attributed to a number of key issues. For example, the older vectors which are used to insert the genes were unstable, with the propensity to introduce clonal rearrangements and therefore mutagenesis and cancer. A major breakthrough came when lentiviral vectors were developed. These are derived from HIV and extensively investigated and optimized over the past 2 decades, with the ability to infect quiescent cells, package large transgene cassettes, and they also have reduced genotoxicity in the vector design, being self-inactivating, that is to say, they prevent the transcription of the viral genes. There are 3 general strategies for gene therapy in the haemoglobinopathies. The addition of a gene such as the beta or gamma globin gene or an anti-sickling beta gene knockdown to improve the phenotype, such as knocking down the alpha globin gene in beta thalassemia to reduce the imbalance of alpha and beta, and editing of the globin gene or their regulatory elements, for instance, of the gamma globin gene to enhance fetal hemoglobin to benefit both thalassemia and sickle cell disease. Today, I will be talking about the most common, namely gene addition, in which our thalassemia and haemoglobinopathy unit at RPA has had experience, and what has been a very hot topic of gene editing, both of which have relevance to sickle cell disease. Here is the construct that is used for gene therapy in the trial that we were involved. It's given the name of BB305. It's basically derived from a lentivirus into which the beta globin gene, which is modified at a particular codon called 87, leads to an amino acid change such that the transgene globin can be easily monitored by a process called HPLC, but does not alter the function of the beta globin. Expression is driven by the erythroid-specific globin locus control region, or LCR. And there were some studies which were in preclinical, that is before in human, which showed that the expression of this globin corrected mouse models of both beta thalassemia and sickle cell disease. There was also an early phase trial in which thalassemia major patients were treated in 2014 and was successful. This then led to the trial we participated in Sydney called HGB204 or North Star, which is an international multi-center phase 1-2 study in adults with thalassemia major with 4 US sites, 1 Australian site and 1 Thai site. And here is the general treatment procedure, which is very much applies to sickle cell disease as well. Firstly, CD34 positive stem cells are mobilized by GCSF and plerixafor. These 34 positive cells are then selected, transduced with that lentiviral vector I showed you, and then cryopreserved. I'll mention for that this particular trial, this entire mobilization and manufacturing process was performed in the United States, such that our 2 patients who were enrolled had to travel there. After their return, we performed myeloablative, so chemotherapy, busulfan conditioning, and then the modified cells were then reinfused. The median time to engraftment of neutrophils was 18.5 days with a range of 14 to 30 days. So this is long compared with autologous transplant for cancers, while that for platelets was even longer at a median of 39.5 days with a range of up to 191 days, that is more than 6 months. However, despite this long platelet engraftment, there were no bleeding complications resulting in serious adverse events. And here's the safety summary of the 18 thalassemia major patients in the North Star study. All the serious adverse events of grade 3 or above are listed on the left and are non-drug related, with 2 cases of veno-occlusive disease, 1 case each of Klebsiella infection and cellulitis, 1 cardiac thrombosis, and a case of hyperglycemia. Grade 3 and 4 non-hematologic adverse events are listed on the right. These were considered as expected of the myeloablative chemotherapy with stomatitis, febrile neutropenia, and pharyngeal inflammation, and all were considered non-drug related. In contrast, all 4 drug-related adverse events were mild. Grade 1 of abdominal pain, as you can see on the left, shortness of breath, hot flush, and chest pain. And I'll just show 3 slides on the efficacy of the gene therapy in relation to thalassemia from this trial that we were involved in before moving to sickle cell disease. For thalassemia, at the time of publication of the study in 2018, patients had been transfusion independent for up to approximately 42 months, that is 3.5 years, with a range from 113 to 41.9 months. And as I'll describe to you in a moment, one of our patients has remained transfusion independent now 6 years after the therapy with a hemoglobin of 133, whereas previously he was receiving 3 to 4 units of PAC cells every 4 weeks. And a further update of these results from ASH last year showed that 14 out of 22 patients, that is 64% of patients in the earlier phase trials, are now maintaining transfusion independence at a median of over 4 years and up to with a range of up to almost 6 years. In addition, the results appear to be further improved in the later phase trials shown in the red, in which in the red words, in which 9 out of 10 patients, that is 90%, have become transfusion independent with an improved manufacturing process. And the improved efficacy can also be seen here in the average hemoglobin, which has increased from 10.4 to 124 to 125 grams per liter of hemoglobin. In addition, all patients who achieve transfusion independence have been able to maintain it. Now going on to sickle cell disease, which is the subject of this meeting, this very same lentiviral construct, which we used and which I showed you just now in the thalassemia trial, can be used in sickle cell disease because the amino acid substitution, here you can see from threonine to glutamine, is itself anti-sickling because it prevents polymerization with the sickle beta globin. And as we know from clinical practice, as long as there is 30% or more of anti-sickling hemoglobin, which in this model would comprise both the transgene, that is the transduced gene therapy product, and fetal hemoglobin, we would expect clinical benefit in reducing sickling. So one of the first reports of this treatment was in 2015 by Dr. Cavazzano. The key enrollment criteria at the time was patients between 3 and 35 years with poor prognostic risk factors and an inadequate response to hydroxyurea. At the time, she presented a patient who was a 13-year-old boy with hemoglobin SS, so homozygous sickle hemoglobin. His prior treatments comprised 7 years of hydroxyurea with continued vaso-occlusive episodes, and he had been on monthly transfusion for a number of years with some improvement. However, he still experienced 1 to 3 vaso-occlusive crises per year on hydroxyurea, 2 acute chest syndromes, bilateral hip osteonecrosis, and had undergone a splenectomy. And here are the results in this patient. You can see that the expression of the transgene shown in red was 47%, which when added to the hemoglobin F of 2% amounted to 51%, which is in almost equal ratio with the hemoglobin S. And clearly the 51 is above the 30% threshold I mentioned for clinical benefit. Impressively, at the time of this report at 1 year, this patient was weaned off transfusions, had no hospitalizations or acute sickling events, had reduced hemolysis with reduced reticulocytes and LDH, and the oxygen dissociation was similar to that of a sickle cell carrier. As a result of this, a larger phase 1 trial was commenced called the HGB-206. The same treatment structure was followed as I showed you for thalassemia, with stem cell collection, lentiviral gene therapy, followed by myeloablative chemotherapy conditioning and the infusion of the modified cells. This study was reported at ASH last year, concentrating on a cohort called Group C, which refers to sickle cell disease patients who, like in the thalassemia trial, had autologous stem cells mobilized from the peripheral blood by plerixafor and G-CSF, as opposed to the 2 other cohorts in whom bone marrow cells were harvested, because there was an initial concern, which has proved not to be the case, that if you mobilize peripheral blood stem cells using G-CSF and plerixafor, this could precipitate sickle cell crises. The second Group B also used bone marrow cells, but those patients also had a hypertransfusion regime carried out before the stem cell harvest, the aim being to reduce the erythroid predominance in the marrow to increase the stem cell yield using transfusion to suppress the erythroid cells, but this also proved not to lead to any difference. And this is why cohort C was expanded and reported last year, being much easier because the stem cells were harvested from the peripheral blood. Here you can see the enrollment criteria of between 12 and 50 years of age of homozygous hemoglobin S or compound heterozygosity for beta S and either beta 0 or beta plus thalassemia genotypes. These patients had a history of severe vaso-occlusive events, and these patients also have either failed hydroxyurea or are intolerant of it. On the right, you can see that 43 patients underwent mobilization and apheresis. 3 had discontinued due to withdrawal of consent or investigator decision, and there was 1 mobilization failure, so could not obtain the stem cells from the peripheral blood. There was also 1 patient who died, but this was unrelated to the trial procedures. At the time of the American meeting last year, 39 patients had had their cells manufactured, of whom 32 had completed infusion with a median follow-up of 13 months, ranging up to 31 months. And here are the key targets to achieve with a transgene hemoglobin of 30% or more to reduce sickling, total hemoglobin increase of 30 grams or more, or a total hemoglobin of 100 or more, and a 75% reduction in pain episodes by 24 months after the infusion. Patients were defined as having severe sickle cell disease with a history of recurrent vaso-occlusive crises, acute chest syndrome, stroke, or evidence of pulmonary hypertension. The age range was between 18 and 42 years. The white blood cells or neutrophil engraftment was 19 days with a range up to 27 days. Platelet engraftment 28 days, but a range much longer of up to 136 days. Both much longer than what we usually expect from autologous transplant, but as you can see, very much comparable as the thalassemia studies that I showed you. All patients were able to stop red blood cell transfusions by 90 days post-treatment. Here are the levels of hemoglobin that were presented at the American meeting. For patients with a follow-up of 6 months or more, The median total hemoglobin shown in the blue by the 6-month mark had increased from 89 to 118 grams at 6 months and remained stable over the 30 months of follow-up, although at 30 months there were only 3 patients at this time point. In addition, the transgene, so the transduced anti-sickling hemoglobin, which is shown on the red, was found to be 40% or more by 6 months, and it also remained stable and therefore also higher than the threshold of 30% to obtain clinical benefit. In vitro studies also show that the transgene hemoglobin was expressed in almost every red cell. That is, it's near pancellular at 6 months or more, and by 18 months, approximately 90% of the red cells expressed the transgene hemoglobin. This is important because if it was only present in a fraction of the cells, then the other red cells could still sickle. Measurement of the sickling also showed that the propensity of red cells to sickle was comparable to a sickle cell trait patient, that is someone who is a carrier. There were also clear improvements in the key hemolysis markers, trending towards normal LDH, reticulocyte count, and total bilirubin. And here you can see a diagram from an earlier report showing the decline, especially in the first 6 months, of all these markers of hemolysis or red cell breakdown. But here are the particularly pleasing results. In 14 patients with 6 months or more of follow-up and a history of vaso-occlusive crises or acute chest syndrome, you can see from this slide that there was a marked decrease in the occurrences of crises and acute chest syndrome from before the gene therapy, as shown on the left, with the sickling episodes shown as the red dots, compared with after the gene therapy shown on the right. The annualized rate of crises was 4 with a range of 2 to 14 before the gene therapy and was 0 after the gene therapy, leading to a 99.5% reduction in crises. And there was only 1 episode that occurred at about 3.5 months for 1 patient after the gene therapy, and this was not considered to be serious. In addition, patients were also asked to record the severity of their pain using a system called PROMIS 57. Those patients with baseline pain intensity scores that were worse than the usual population, shown in orange on the top line, reported clinically meaningful improvements in pain reduction at 12 months post-treatment, whereas patients with scores which were near or better than the population norm had at baseline remained stable over the time period of their treatment. Like thalassemia, the safety profile of the gene therapy was consistent with the effects of using the chemotherapy for conditioning. The most common non-hematologic grade 3 or above post-treatment adverse events were stomatitis and febrile neutropenia, occurring in 60% and 44% respectively, whereas serious adverse events occurring in 2 or more patients were nausea, opioid withdrawal syndrome, and vomiting, all occurring only in 2 patients. Whereas for those patients who did have lentiglobin or gene therapy related adverse events, they were all mild of grade 1 or 2. There has, however, been 1 death which was considered unlikely related to lentiglobin of more than 18 months post-treatment in a patient with significant baseline sickle cell disease related cardiopulmonary disease. There have been no events of graft failure, vector-mediated replication-competent lentivirus or clonal dominance, such that mutagenesis was considered unlikely, as reported in ASH last year. However, it was in this trial earlier this year, a few months after ASH, that a case of acute myeloid leukemia was reported. This resulted in an FDA hold of the trial while investigations were conducted to review possible causes, such as by analysis of the integration sites of the vectors with respect to clonality, potential oncogenes, and the levels of the replication-competent lentiviruses. Earlier this year in February, it was revealed that the patient had significant chromosomal abnormalities and mutations in genes associated with acute myeloid leukemia, with RUNX1 and PTPN11 mutations in the AML cells. And that while preliminary findings suggested that the vector was present in the leukemia blasts, there was not sufficient information to determine causality. After further investigation, the conclusion was that it was very unlikely that the leukemia was related to the lentiviral vector, because although the integration site of the vector was found within a gene called VAMP4, this gene had no association with myeloid leukemia, nor with cellular proliferation or genome instability. There was also no significant gene dysregulation that was attributed to the insertion event. Therefore, the trial is no longer on FDA hold, but the provision of standard of care therapy for thalassemia, which had already been approved in Europe, has, to my understanding, not yet restarted. And I guess overall, it will be more of a watch this space situation. I would now like to turn to briefly describe our two patients in the North Star trial, as even though they were in thalassemia rather than sickle cell disease, it would perhaps provide some understanding of local experience. The first was Mr. W.S., who was 35 at the time and now 41. He was of Thai ethnicity and has been undergoing transfusions every 4 weeks for some years. He had a gene therapy in March of 2015, which was essentially uneventful, with the acute adverse events being mucositis, febrile neutropenia, and skin rash. However, he did have a delayed platelet recovery shown on the right. But even now, even though the day 27 was in fact below the median for the trial, even now he does have a chronic thrombocytopenia of about 80. 1 year after the gene therapy, we performed a bone marrow biopsy, and of interest, the megakaryocytes were normal, indicating this was more likely attributed to a peripheral destruction process, noting that the spleen was not enlarged and not related to either bone marrow dysplasia or reduced production. Pleasingly, he has been transfusion independent now for 6 years, with the latest hemoglobin being 133, and with normal cardiac and liver iron and good ferritin. As you can see, he ceased iron chelation about 2 years ago. In contrast, the other patient was a young lady of Chinese ancestry who was 27 years at the time of therapy. Again, the course of the autologous transplant with the gene-modified cells was uneventful, with mucositis, febrile neutropenia, Staph aureus sepsis, and cellulitis. However, the two main issues are firstly that she did not become transfusion independent, because although the transfusion burden has now decreased to 1 to 2 units every 4 weeks, she is continuing to need transfusion, and it's likely that this will continue in conjunction with iron chelation. A further important and difficult issue is her infertility. She had 3 embryos stored before the procedure, but having undergone 2 IVF procedures last year, unfortunately both were unsuccessful, and she's planning for her 3rd attempt later this year. A few weeks ago, we also learned that she was diagnosed with an atypical placental site nodule in a hysteroscopy, which was being performed for assessment of her fertility, and we will have to continue to review this to determine whether there is any relationship with the gene therapy. I'll next turn to talk about globin gene editing as a form of gene therapy, noting that while we now have not had any experience with thalassemia and sickle cell disease, we have had experience with this technology in our chimeric antigen receptor T cells, which is a form of immune therapy for cancer. And so because we haven't done this in either thal or sickle cell disease, I'll be summarizing the important data from the presentations in literature, which has been very exciting. As the name implies, gene editing indicates that the gene is edited, and this can be performed by 3 main enzymes: the zinc Winkler nucleases, the transcription activator like effector nucleases or TALENs, and the very famous CRISPR-Cas9 system. The basic principle for all of these nucleases is to create double-stranded breaks at precise locations in the genome using different DNA recognition mechanisms. And then the DNA repair process then introduces a deletion or mutation. A key gene in the gene editing for haemoglobinopathies is called BCL11A, which is shown on this slide. It is a potent suppressor of the gamma globin genes and therefore of fetal hemoglobin production. Therefore, gene editing to inhibit BCL11A could potentially increase fetal hemoglobin production for the benefit of both sickle cell disease and thalassemia. And I attended this talk in ASH in 2015 when a group from Boston used the CRISPR-Cas9 system to target a particular sequence in the enhancer of BCL11A without affecting the red cell maturation. And the results are shown in the red rectangles, where you can see in the second column in the middle, there's an increased gamma globin in the dark blue, an increased hemoglobin F cells on the right-hand side, in that diagram, as compared with the control in the first column and an older procedure using zinc finger nucleases in the third column. These authors further indicated that they were able to achieve clinical grade edited mobilized CD34 cells, predicting the translation of similar processes to the clinic. Therefore, amazingly, a short 5 years later, this clinical study was first presented at ASH last year and then published in the New England Journal of Medicine this year, reporting 1 patient with sickle cell disease and 1 patient with beta thalassemia treated with CRISPR-Cas9 gene editing of BCL11A. I will only discuss the sickle cell disease patient who was a 33-year-old lady homozygous for the sickle mutation with a single alpha gene globin gene deletion. Here you can see that the patient has a history of per year of at least 7, or a median of 7 severe vaso-occlusive crises, 3.5 hospitalizations and 5 red cell transfusions. She had chronic pain, gallstones, increased LDH, and decreased haptoglobin. CD34 positive cells were harvested, as I mentioned, which were mobilized again by the same medications of plerixafor and filgrastim. CRISPR-Cas9 was then applied with a single guide RNA, as shown on the left, to target the enhanced region of BCL11A so as to restore gamma globin synthesis and reactivate the production of fetal hemoglobin, which you can see on the right in this increased height of the column for the edited cells. And as you can see, as before, the patient underwent busulfan myeloablative conditioning and then was infused the cells. By 3 months, the fetal hemoglobin, which is shown in blue, had increased from 9.1% to 37.2%, and then remained above 40% after 15 months. Bearing in mind again that the fetal hemoglobin, which is the non-sickling portion, must be at least 30% to have a clinical effect, and clearly this was above 30%. In addition, you can see that, in parallel rather, you can see that there was a marked increase in F cells. These are the adult red cells containing fetal hemoglobin. And importantly, the fetal hemoglobin is not restricted to specific cells, but pancellular, that is over 99%. And in addition, on this diagram, you can see the dramatic reduction in this patient in both vaso-occlusive events shown on the top and transfusions after the gene therapy in the second line with the follow-up here of 9 months. Here you can see that there were no transfusions since day 19 of the treatment, and the total hemoglobin at the last visit was 118 grams. A third way of making things better for sickle cell disease by gene therapies is by adding the gamma gene to increase fetal hemoglobin. At ASH last year, this abstract was presented of ARU 1801, which is a gene addition process for gamma as opposed to beta. Again, the addition is by a lentiviral vector. The gamma gene was also modified to increase its anti-sickling potency. This is because the point mutation increases the fetal hemoglobin levels per vector copy in the red cells, because the mutant fetal hemoglobin binds the alpha globin with a higher affinity. The mutation also makes the fetal hemoglobin more potent in its anti-sickling property. The hope is that this would mean reduced intensity conditioning for the autologous transplant, and so that rather than myeloablative, so wiping the entire marrow conditioning, this trial used a relatively low dose of chemotherapy of melphalan, as shown here, in the hope that the side effects would be reduced. And in ASH last year, the presentation was of the more long-term data of 2 patients who were previously reported, together with an additional patient who received a product with an improved manufacturing process. The first 2 patients had shown a stable expression of the hemoglobin, mutated fetal hemoglobin of 20 to 22% over 2.5 years. And although both were under 30%, they have maintained improvements in vaso-occlusive events. Whereas the third patient was the particular interest. He was a 19-year-old who had hemoglobin SS, or homozygosity, with 6 months follow-up, using again an improved manufacturing process of the modified cells. He had a favorable safety profile with no treatment-related adverse events to date. Interestingly, the white cell or neutrophil engraftment was between 7 and 9 days, and the platelet recovery was between 6 and 12 days. So as you can recall, this is much shorter than the lentiglobin that we were using. And this could be due to either the product or because the lower level of chemotherapy was used. And here are the results of that third patient, where you can see a rise in hemoglobin to 133, while the hemoglobin F and the transgene hemoglobin shown in the red and the brick red columns was approximately 30% at 9 months, and therefore better than the first two patients. There were reduced hemolytic markers of reticulocytes, bilirubin, and LDH, and importantly, there were no vaso-occlusive events or no crises to date up to 9 months. To summarize, I took this diagram from a paper about 3 years ago indicating all the potential technologies that can be developed for gene therapy in sickle cell disease, so as to illustrate that I have merely described 3 methods: the addition of anti-sickling beta globin, the gamma globin addition, and also the fetal hemoglobin induction by silencing of the BCL11A. There are, in fact, as you can see, many other possibilities, such as the direct correction of the sickle mutation by gene editing, or other ways of increasing the fetal hemoglobin, such as by generating mutations of a condition called hereditary persistence of fetal hemoglobin called HPFH. So you can see the list is long, but I have mentioned the 3 that appear to be at the forefront. Finally, and importantly, it is critical to emphasize that though very exciting because of the potential benefits, it's still very important to be aware of all the risks and ensure, especially in clinical trials, that this is fully understood by all patients. Firstly, the toxicity of the conditioning, that is the chemotherapy, both short-term, such as mucositis and veno-occlusive disease, as well as long-term, such as infertility. There is a possibility of graft failure, as well as the ever-present concern of clonal dominance, insertional mutagenesis resulting in cancer. Off-target gene editing can lead to loss or gain of function of other genes, and finally, the enormous cost involved, which at the moment anyway, which can really be described as astronomical, as the product which we used in the North Star trial is now approved in Europe at the cost of $1.8 million per patient. So my concluding thoughts are as listed here. As I come to the end, I hope I've been able to show you that there is great excitement ahead in gene therapy, including gene editing. A clear understanding of the risks and challenges is very important. However, in looking at these future options optimistically, we also have to confront the current realities of the suboptimal use of therapy, including that of hydrea. Hence, clearly efforts in developing new therapies and new technologies must occur hand in hand with improving current modalities for the benefit of our patients. And finally, I'd just like to thank my colleagues, especially the senior nurses of the RPA unit, Stephen and Melly, my fellow and registrars, whom I'm continuing to encourage to be interested in the hemoglobinopathies, Professor John Rasko and his colleagues in the Department of Cell and Molecular Therapies, our apheresis unit and cell lab, the trials unit, and all my colleagues in the hematology department at RPA. But last but not least, the patients and families who put their trust in us. Thank you.
Thank you so much, Professor Ho, for that very informative session. This is what we've been looking for, and hoping that one day it can be available in the sickle cell community as well. I understand, you've done that one treatment for the thalassemia patients. Do you think in the near future you would do clinical trials for sickle cell patients as well?
It is very much our wish and hope to do so. But as you can see, obviously the amount of technology and infrastructure is, demands a lot of resources. And I remember hearing a question just now in one of the sessions and also on the chat that as the numbers of patients in Australia are not very big, it is always more difficult, I guess, to attract the sponsors of such studies to come to our country. Nevertheless, it doesn't stop us from trying, and we continue to try to advocate for these trials to come to Australia, because despite the numbers of patients, which are relatively small compared to say the US, we are an extremely good country to perform clinical trials because of the systems that we have put in place for safety and for monitoring.
I can attest to that. My daughter went through a bone marrow transplant. Unfortunately for us, it was pretty good experience, no much side effects. We have one question here. It talks about the age. What's the minimum age? Is there any age you'd recommend, for somebody to do this trial?
Yeah, so the age is very much decided or determined by obviously the sponsors of the trial, but you will see that in the sickle cell disease trial, it did go down to children. So I have to say that in my personal opinion, due to the trials being still at a relatively early stage, it is much more complex to, perform experimental therapy in children, and one would probably advocate for at least adolescents upwards.
Well, thank you so much, Professor Ho. Again, this was a very informative session, and we just hope for science to improve in future, where we have less risks and complications and less expensive, because I can't imagine where it's costing $1.8 million. Who would afford that? So hopefully when it's available, it can also be easily accessible in terms of cost, because I like science and everything that's going on, but if you make it so impossible for the patients to be able to access, I don't think it's going to be a success at all, because you want people to actually be able to afford these things.
Yes, yeah. I completely agree with you, Agnes, and we certainly hope that, like all technologies, with developments and with it becoming more common, hopefully that would be a problem that would be solved in terms of the ability to make it available to more people when it is very safe. Yes.
Well, thank you so much. I'll let you go and have a lovely weekend. We have Dr. Kylie Mason. I think the other session has started that we can